Hi, this is Brian Kim. I'm going to share with you this technique of placing an absorbable adovarchal suture in patients who you really have no way of technically being able to remove their suture in children and or handicapped patients who can't get to the slit lamp after their cataract surgery and you wanted to place a suture, or if it's a patient with dementia or again handicapped and you're worried that they're going to rub on the eye and potentially cause a problem. You can place the suture, but you're like, man, if I put a 10-0 on, I won't be able to take it out at the slit lamp. The patient can't be seen at the slit lamp. And so putting an adovarchal suture is really advantageous. One, it's readily available. Most of us have it on the shelf. You don't have to special order a 9-0 Vicryl or a 10-0 Vicryl or something like that, because you'll rarely use this technique. But when you have to, it's really, really helpful because you can place the suture in such a way that you don't have to really bury the knot because it's already buried for you, and because it's absorbable. You know that it's going to do its job and keep the wound nice and tight and closed, even if the patient rubs on the eye, and it gives you that 1 to 2 weeks of protection as it keeps the incision sealed. And so this is a technique. I'm placing it through the incision, so that space between the roof and the floor, I'm first suturing the floor on the scleral side, and then I'm going through the roof side, and you want to lift the roof side with the forceps, and you want to be able to exit right in that gap between the roof and the floor of the incision. If you accidentally grab fibers from the floor, then you're not going to be able to bury the knot here. And so that's the key with this technique. Once I place the suture this way, I make 2 throws, and then I go ahead and cinch it down. But remember, Vicryl is braided. It's very, very sticky and tough. It doesn't want to slide. It's not like nylon. And so you can see I'm using my fingers here to give myself a little bit extra leverage as I'm trying to tighten down the suture here. And once it's tightened down, you can see the knot is actually within the incision here. Now it is exposed, but that's okay. And then I'm going to use the McPherson forceps, and I'm going to go ahead and just gently rotate it. And when you rotate, you don't have to do a lot of rotation, but you can see now it's actually underneath the stroma right there in the incision, and there's no externalization of the knot or the tags here. And then you hydrate your incisions, and that's the end of the case. So this is the first eye of the patient. This is the second eye of the patient. So again, I place that suture. The first bite is through that gap of the incision, placing it into the stroma on the floor side, into the sclera, and then using forceps to grab the roof of the incision, lifting it up. And I'm starting far back so I get a nice meaty bite. And right here, you want to make sure you don't grab the floor of the incision right there, because otherwise you'll get stuck. You won't be able to rotate that knot. And before I tie it down, I fill the eye with some more BSS to get a nice chamber stability. Because if you don't want to over tighten the suture, and then it's going to cause astigmatism and so forth. And so this is really the best way. You put a little fluid in, get a nice pressurization, and then cinch it down. I like to use my hand here because again the Vicryl is braided, and there's a lot of resistance when you're trying to cinch down the suture. You cinch it down, and then you cut it, and then bury the knot. And again, because the suture placement is within that gap in the wound, the knot naturally goes down into the wound. But then, of course, it could be exposed a little bit. And so with gentle forces, you're able to rotate the knot. You can see the knot now is not within the wound there. It's actually into the stroma. And so that's really the case. It's really a very easy technique, placing the needle first in the gap between the roof and the floor of the incision, take a bite through the floor, and then going around and taking a bite of the roof, making sure you're not grabbing any fibers as you externalize the needle. And then again, using your hand to cinch it down, because the braided sutures really has a lot of friction when you're trying to pass that suture through the cornea and the sclera. Once you cinch it down, you cut it, and then you pull just a little bit and rotate the knot, and then it goes into the corneal stroma, and then you're good to go. So again, this is my technique on how, in really challenging cases and patients you're not be able to examine very well after surgery, and you're worried that they're going to rub the eye or mess with their eye, and you want to place a suture rather than using a nylon, which you would have to remove later on because it's going to break and get infected. I'm using the Vicryl suture technique. In this way, you don't have to worry about taking it out, and it dissolves on its own, and it does its job. So I hope this was helpful to you, and I thank you for your attention.